Uh, I think it is 8 o'clock, sir. We'll start the JC. So, a very good evening to all of you. So, we are pleased to resume the Indian Society of Nephrology's monthly journal club. We have a captivating article on green nephrology, which has been recently published in KI Reports, featuring research conducted by our esteemed colleagues from MMC Chennai. Dr. Pratik Shirke, senior resident in KEM Mumbai, will be presenting this study. Dr. Valentine Lobo sir from KEM Hospital, Pune, and Dr. Humapati Egde sir from Nadiad have been joining us as panelists. And we are also honored to have the study authors, Dr. Gopalakrishnan sir and Dr. Shakti Rajan, to join us for this discussion. I request the attendees to post your questions in the chat box and we'll be addressing them after the discussion. Over to Dr. Pratik to present the journal.
Good evening, everyone. So today we'll be going through a pilot study regarding the new concept of eco-friendly hemodialysis with a novel prescription. So coming to the global prevalence of chronic kidney disease, it is estimated that around 0.07% there is prevalence of CKD with approximately 5 million patients in 2017. So there is a rise of patients with end-stage kidney disease by 6% per year. And these numbers of the patients requiring hemodialysis are it will be approximately doubled by 2030, which comes to about 50 lakhs. On a global scale, 600 million hemodialysis procedures are performed annually. So hemodialysis by itself is a very resource-intensive procedure. A single session of hemodialysis requires water consumption of up to 500 liters, energy consumption up to 7 kilowatts of energy, and it generates 1 to 2 kilogram of medical waste. So, if we consider for a single for treatment of a single patient, around 78,000 liters of water is consumed. And if we take into account the consumption by all dialysis patients, so it comes to 270 billion liters of water on a global scale. As with regards to city of Mumbai, there are around 10 to 12,000 patients. So the daily water consumption goes to up to 60 million liters. So in the background of water scarcity, like what Bangalore is facing as of today, if we consider only in a city of Mumbai, this 60 million liters, if we take into account for a period of 2 months, so that 2 months, the entire volume, the volume of water which is consumed, so it amounts to the daily requirement of the entire city of Bangalore. So this is this much significant water consumption is there by the dialysis procedure. So in green dialysis, this is the pictographical representation of a usual RO plant, which we are well used to. From the main supply, the water goes to reverse the RO unit, and from the RO unit, the ratio usually is 3:1. 25% of the water is goes to the dialysis machine, and the remaining 75% is thrown as reject water. So the reject water by itself, it is considered as a potable water, and it can be directly used for a large purpose of activities like sanitation, laundry, even the spent dialysate from the machine. It can be used for agricultural purposes. And thirdly, the reject water can also be used for in the hospital purposes like steam generation or sterilization. So instead of wasting the water, it can be utilized. So the topic for today, how can we reduce the water consumption in a conventional hemodialysis? So in a conventional HD, solute clearance depends on 3 things: the blood flow rate, dialysate flow rate, and the dialyzer. So if we keep the other 2 constant, just reducing the dialysate flow can lead to substantial water conservation. However, at the same time, there is also a risk of affecting the dialysis adequacy. it can reduce the delivered KT by V. So there are a few studies have been done in the last 2 to 3 decades, which have compared the different dialysate flow rates as regards to the dialysis adequacy. Around 5 studies of 5 studies have compared the dialysis adequacy, and they found there is no difference between even with the low dialysate flow rates. However, 2 studies have demonstrated that if the dialysate flow rate is decreased to less than 200, then the clearance might get affected. And around 4 studies have considered beta-2 microglobulin, and even they have shown to be independent of the dialysate flow. So how much exactly are we going to conserve water by reducing the dialysate flow from conventionally 500 to say 400 or 300? So in a single session, 24 liters can be conserved. So if we extrapolate this to weeks, months, and years, as large as 3,700 liters of water can be saved by a single person. And on a global scale, it comes to 24 billion liters of water which can be consumed. So reducing the dialysate flow might affect the dialysis adequacy. So here we have come up with the novel idea of whether we can raise the dialysate temperature to counterbalance the reduced adequacy of the dialysis. So changing the dialysate temperature, it is an easy maneuver to change the blood temperature. The basic science behind this is a warm dialysate leads to vasodilatation. There is a reduced total peripheral vascular resistance. As we all know, the urea is sequestered. The urea distribution in the body usually 50 to 55% is in the muscles, 20-25% is in the bones, and remaining 10 to 15% is in the skin and subcutaneous tissue. So if we increase the peripheral vasodilatation, this urea can be taken into the intravascular compartment, and it can be and its removal can be enhanced during the actual process of dialysis. As regards to cool dialysis, it has the opposite effect. It might reduce the dialysis efficacy. However, it has been found effective more so during during the intradialytic hypotension. There are less chances of hemodynamic instability, and it has been studied on a large scale with cardiovascular those having cardiovascular morbidities. So we will be looking into the pilot study on the safety and adequacy of novel eco-friendly hemodialysis prescription. The aim of the study was to reduce water consumption without compromising the adequacy and safety of dialysis with the new prescription with high temperature and low dialysate flow. Study hypothesized that the reduction in the delivered single pull KT by V would be counterbalanced by raising the temperature of the dialysate. A trial was conducted to study the safety and adequacy of the dialysate prescription with high temperature, low flow, and it was compared with the conventional dialysis of normal temperature and normal flow. This was a non-randomized open-label crossover pilot study at the Institute of Nephrology at Madras Medical College, and it was done during a period of 3 months. Inclusion criteria being all end-stage kidney patients on twice or thrice weekly maintenance hemodialysis via an AV fistula. Those with ejection fraction of less than 40%, any episodes of intradialytic hypotension, any clinical evidence of autonomic neuropathy, or duration of less than 3 months from initiation of dialysis were excluded from the study. So 3 different prescriptions were used for 1 month each. Those on which comes to 8 sessions for those on twice weekly and 12 sessions for those on thrice weekly. All patients were subjected to 3 basic prescriptions. First with normal temperature, normal flow for a period of 1 month, then high temperature, normal flow for a period of 1 month, and then high temperature, low flow for a period of 1 month each. This is the flow diagram. 109 patients were screened, of which 42 were eligible. An observation period was given for 1 month, during which any adverse events on dialysis, any episode of intradiabetic hypotension was recorded, and 3 patients were excluded. So finally, 30 patients were recruited in the study, and each of them sequentially went into 1 month period each with the new prescription, and then the results were analyzed. It was done with a Fresenius 4008 machine with F6 polysulfone dialyzer with a surface area of 1.3. Blood flow rates were kept constant at 300 ml per minute. Unfractionated heparin was used for anticoagulation, and the dialyzer was used for up to 8 sessions. It was discarded if the bundle volume was less than 80%. At the temperature was checked during the initiation and termination of dialysis with a Burer non-contact infrared thermometer. BPs were recorded both initially at the end and in every 30 minutes into dialysis session with the automated BP cuff in the 4008 machine. Any adverse events like hypotension were recorded during the study. The primary outcome was the delivery of adequate dialysis, which was calculated using single pool KTPV and urea reduction rate. And it was compared between normal temperature, normal flow, and high temperature, low flow prescriptions during every session for a period of 3 months. Secondary outcomes had compared single pool KTVV urea reduction rate at every session, any changes in the body temperature and blood pressures, and whether any adverse events occurred or not during the study period. These were the statistical methods used. The baseline data of the population, majority were young patients around the mean age of 37 years, male predominant, with an 80% having distal AV fistulas, predominantly non-diabetic, and no major cardiovascular morbidity. When the primary outcome was compared, it is seen that in both the prescriptions with normal temperature, normal flow, and high temperature, low flow, it did not show any significant difference. As compared to the secondary outcome, the first box and whisker plot is suggestive of comparison of single pool KT by V between the two prescription, and the second whisker plot has urea reduction rate between the two. So even here, there was no significant difference between the two prescriptions. The significant difference was between the temperature, which was more in high temperature, low flow prescription. Otherwise, single pool KTYV urea reduction rate, any hypotension during dialysis or adverse events were not recorded between both the two prescriptions. So by this study, just by reducing the dialysate flow from 500 to 300 ml per minute, it has saved the water consumption from 120 to 72 liters. So almost 50 liters of water has been saved. So if we extrapolate this to a normal dialysis unit, considering 10 beds and 3 sessions per day, it amounts to as large as 1400 liters of water which can be saved. And the RO membrane, which works at a ratio of 3:1, it scales up to 4,000 liters of water, which can be saved per day. By increasing the temperature in the high temperature, low flow prescription, temperature increases the Brownian motion. So the velocities of the small solutes increases, and there is increased bombardment of these molecules into the dialyzer membrane, thereby increasing diffusion and thereby increasing the clearance of low molecular weight solutes. Also, total peripheral vasculature is reduced, and the skin blood flow is increased. So in normal resting state, the skin blood flow is around 250 ml per minute. However, when it comes to heat stress, this blood flow can be as high as 8 liters per minute. So by increasing the blood flow rate, uh, urea compartmentalization can be reduced and the dialysis efficacy can be increased. The third point being, it also reduces, high temperature reduces the viscosity, thereby favoring diffusive transport. The third arm in this prescription, the third arm in this study was the high temperature normal flow prescription, which was used as a proof to document whether it increasing the temperature really makes a change or not. So in this, all three prescription have been studied with regards to primary and secondary outcomes, and we can see that the high temperature normal flow arm, whether it is compared with both the if we compare it with either the normal temperature normal flow or the high temperature low flow, it is a significant with regards to the primary and the secondary outcomes. Without any difference in the hypotension or any adverse event during the study. The strength of the study, there are not much previous data available as regards to increasing the temperature of the dialysate. There are studies which have allowed use of low dialysate flow, but with regards to increasing the temperature, this is quite the sample size of the study is large, and it was adequately powered to assess the intended primary outcome. Some limitations are the subjects which have been taken in the study are usually they are young patients, non-diabetic and with low cardiovascular morbidity. Urea distribution was done by conventional method by Watson formula, wherein current more sophisticated methods like bioimpedance spectroscopy and isotope dilution methods are available. And measurement of skin blood flow rate was not done. The dialysis adequacy, single pool KT/V and urea reduction rate are one of the few parameters with regards to adequacy. However, there are other parameters like quality of life, subjective global assessment, which are also important during and which should have been taken into account. A blood flow rate of 300 was kept for all patients. However, if we see usual patients with who come for dialysis, achieving a blood flow rate of 300 for everyone might not be possible. The dialysis unit temperature was kept at 25 degrees Celsius in this study. However, there might not be all centers who have equipped with air conditioned or in some states or some cities wherein the outside environment temperature is high. So here the temperature variations might affect the results of the study. And interdiatic interventions like for any episode of hypotension or during the 4-hour session, whether any bolus was used to maintain the hemodynamics or any other event was not does not mentioned in this study. Whatever said and done, this is a new study which has been carried in a government setup with a large population and which it has to be. We appreciate the study, sir. Thank you. That was it.
Thank you, Dr. Pratik. That was a nice presentation. I now invite the panelists, Dr. Valentine Lobosar and Dr. Umapati Agdesa, to initiate the discussion.
Okay. Should I go first or is Dr. Hegde going?
Please, Dr.
Great. Okay. So yeah, I agree, Dr. Pratik. Can I ask you a question? Uh, of course, it mean you are presenting a study from a journal, but you showed us at the start that every HD session uses 7 kWh or units of electricity in terms of power, and you also and you showed us a water saving. Now, is it just possible that when you have to raise the dialysate temperature instead of 37 degrees to 38.5, that there may be the benefit in terms of water saving could be counterbalanced by an increased energy use?
Actually, sir, we have looked into that matter also, but we have spoken to our engineers at Fresenius, and by far, as of now, they feel the temperature. We can maintain the temperature from 35 to 40 degrees, and there will
40? No, above 39 degrees, the machine will go into bypass automatically.
35 to 39 degrees, sir. So it
Start
won't.
getting hemolysis early. So till 38 and 39 is beyond that. It goes into the bypass not to protect the kidney, protect the person.
So
Yeah, so I just did the calculation based on the data which the authors have given us. They said that in the AC atmosphere, the temperature is 25 degrees, and that the two temperatures used in the study, 37 degrees at and 500 ml per minute of flow, and 38.5 at 300 ml per minute flow. So assuming the specific heat of water to be 1, and assuming that you would raise the temperature, I calculated that heating the water, that is the dialysate, to 37 degrees at 500 ml per minute uses 1506 kilojoules of energy per session. And for 300 ml per minute at 38.5 degrees centigrade, it is 1017 kilojoules per session. So there is actually not just a saving in terms of water, but there is also a saving of 489 0.76 kilojoules per hour in terms of energy requirement by a slower flow, higher temperature dialysate in this study. And assuming power consumption in kilowatt hours, each session per each machine per session would save around 0.13 units of electricity. And when they said that there are 10 machines running 3 shifts, they would save about 40.8 units of electricity per day, with even at the temperature of 38.5 if you used a dialysate flow of 300 mils per minute.
So Lobo, it is basically because you are reducing the flow from 500 to 300.
Exactly. So
because even though you are increasing the temperature from
exactly
37 to 38.5.
Yeah. So the energy used is equal to specific heat into volume, since water into mass, so into the difference of temperature. So since the density of water is 1, the ml is equal to mass in grams. So I worked that out and I found there is actually a significant energy saving also, not just water saving, but energy also. Dr. Sharkey, you said, and even the study says, that the reject to purified water ratio is 3:1. That is a highly inefficient RO, because that would mean that this is probably a single membrane RO. All the membranes that are available, Lentec, Dow, and Hydronautics, the 3 commonest ones, have a 4:1 ratio. But if you put 2 membranes, then the ratio of reject to product drops down to 1.7:1. If you put 3 membranes, it comes 1:1. And if you put 4 membranes, then it is 2:3. So you can actually push your product water higher than the reject water with 3 or 4 membranes connected in series. And it would not result in a compromise in the water quality, provided most of the high pressure pumps have got a bypass next valve next to the pump. Now, vendors will usually try to reduce the pressure down to about 5 to 6 kg per square centimeter by allowing a significant amount of water to bypass the high pressure pump and go directly to the membrane on the basis of the raw water pump, which is not a recommended thing, because it's recommended, the membrane manufacturers recommend that the membrane works best at 10 kg per square meter. So the bypass valve should be completely closed, at which time you will get a maximum efficiency, because the higher the pressure, better is the salt reject also. So I think you can today, you can assume fairly correctly that most membranes, most RO systems would be at 1:1 or 2:3, even in the most efficient one. So the RO saving may not be as good as uh, uh, has been calculated. And of course, you would have to find out. I noticed that Dr. Sanjay Agarwal has already asked about sample size, how it was calculated. We leave it to the study authors to tell us. I did run a sample size calculation, assuming this to be a non-inferiority study. So I actually use sealedenvelopes.com, and they gave me a much higher sample size, but we will leave that to the authors to tell us about that. The interestingly, while they assumed, as most of us would, that 90% of our normal dialysis would give us a KT by V of greater than 1.2, and so we would accept a non-inferiority margin of 80%. In the study, actually, even in the routine group at 500 ml per minute, the normal flow at 37 degrees, they achieved the KT by V of more than 1.2 in 70.14%, and that dropped to just about 68.75. So the difference was actually much closer than even what they had assumed. So the non-inferiority would have been met, I think, in any case. But what it does tell us is that perhaps we need to do much more monitoring of our KT by Vs routinely in dialysis. We assume that we do it once a week by the urea method, and we must be achieving that in 90%. But clearly, that's the additional point that this study showed us, that we probably, even in routine situations, it's achieved in about 70%. And so perhaps greater use of the OCMs. Newer machines like the 5008 machine have an autoflow option. And there is a study published in Seminars in Dialysis where they showed that by using an autoflow factor of 1.2, the dialysate could be dropped in that group down to, the dialysate flow averaged about 392 mils per minute at a blood flow of 330, and there was no loss of efficacy. In fact, there was an 8% higher efficacy as compared to the standard group with 500 ml per minute. I think that study is 2012 or 2013 in Seminars in Dialysis. I couldn't pick up the author just now, but I will definitely find it out and post it. So that is the autoflow option is probably good. I don't think that getting 300 ml per minute, as you pointed out, is a limitation, is a problem. Most 90% of patients in my unit get 300 ml per minute, and those doing HDF get 400 ml per minute often. So I don't think, and as far as the temperature difference is concerned, that 0.066 is statistically significant because of the large sample size, but I don't think it's clinically significant. We won't even, probably it comes out in the statistics on average, on the average differences, but really you can't measure 0.066 difference on an individual patient. So those were my comments about it. I'll leave it to Dr. Hegde and others.
Thank you, Dr. Lobo. And thanks, ISN, for the opportunity. A very good study and novel idea of increasing the temperature. Till now, we were seeing reducing the temperature, giving more stableness in arterial hypertension, reduction in the hypotension during the dialysis. But sorry, but those are the studies which have shown equivocal. There is no significant reduction in the URR of KT by V. But by increasing the temperature, you can reduce the requirement of dialysis volume, dialysate volume, and also you can maintain the KT by V. There is one study which was published, I could read, which was published in 2019 by Varadarajan. That was in Journal of Clinical and Diagnostic Research, which he showed that when you reduce the dialysate temperature to 35.5, then the URR, which is achieved in more than 65%, was only in 27.1%. The number of people in each group were 59, as compared to the normal temperature, which was URR achieved in almost around 67.8% of patients. So almost around 40% of the patients had less URR when they have a cold dialysate. So it's the contrary, that you are increasing the temperature and you may having increasing the Brownian movement, and the movement of ions across the membrane may be better, and even the redistribution of the urea, which happens because of the volume and increased temperature, it may give you a good delivery. What, Lobo, any comments? Your mute logo.
They've mentioned the Stokes-Einstein equation for diffusibility, which is equal to the Boltzmann constant into absolute temperature upon 6 into pi into viscosity, which Dr. Shirke also mentioned. So viscosity is in the denominator. So as viscosity decreases with increased temperature into the radius of the molecule. So as viscosity decreases, so you have a higher temperature in the numerator and viscosity in the denominator, both of which will combine to increase diffusion. So the effect is going to be additive probably in this situation. So that's what is there.
I just wanted to ask the author, Dr. Shakti or Dr. Gopal Krishnan, sir, why it was 38.7, why it was 38 was not taken into consideration.
38.5.
Yeah, right. Why it was taken? Because from 37, 38, 38.5, and whether adding even the reduce or the cool dialysate of 35.5, it could have further added the showing that the cool dialysate reduces the URR, and the normal high flow, it increases the URR, and further increase with lower dialysate, whether increases the or equal to the normal flow with normal temperature.
Good evening, sir. First of all, it's a honor and privilege that ISN Journal Club has taken our study, and my immense thanks to Hegde sir and Lobo sir. As usual, Lobo sir hit 2 sixes. I was really thrilled by the knowledge of the rejections, as well as how Lobo sir calculated the temperature, the joules that is required to rise the temperature of the water. I really want to learn from you, sir. So 2 questions I would like to answer. One is the sample size. Actually, even the reviewer has a doubt that whether we have done it as a non-inferiority trial, but we didn't do it in the non-inferiority fashion. We just did it as a comparative one. So the first assumption we had that in the normal temperature, normal flow, that is the standard of care, we will achieve a 90% URR of more than 65%, and 95% of the patient sessions will have a SPKT VVAR more than 1.2. The second assumption is that the steady arm, that is by increasing the dialysate temperature and reducing the dialysate flow to 300 ml per minute, we will be able to achieve at least the same adequacy of dialysis in 80% of the patients. So this is our assumption. So with this assumption, we calculated the sample size. It came to 199 sessions. With the attrition rate of 10%, we kept it to 219 sessions in each arm. So we recruited 30 patients. So finally, we did 288 sessions in each arm, and the presenter presented very well. But there was one adverse event in the high temperature arm. So this high temperature arm with normal flow, one patient has significant hypotension. So we stopped that protocol. So we did only 287 sessions in that. And none of the patients require any clinically significant hypotension and requiring any saline boluses or any other interventions. So this is the safety of the protocol. Regarding the temperature of the, why we selected 38.5. So there was a way back, as we discussed, most of the studies in dialysis was done with low dialysis temperature. So there is one study done by Daugirdas with you et al. So they did for 9 patients with 37.5 degrees centigrade, and only 1 sessions they did, and they proved that there is no big difference in the urea clearance. And also, though there is a drop in BP of from 10 to 15%, there is no clinically significant drop in BP. So this was their observation. So we want to keep it further high, because recently the normal body temperature has been redefined in the meta-analysis to the upper limit of 2 standard deviation is 37.5 degrees. So we increased by 1 degree above this upper limit of 2 standard deviation of normal body temperature to 38.5 degrees. And why we kept another thing is why we kept the third arm, that is high temperature and normal flow arm, is we want to prove that by keeping the flow equal, that is at 500 ml, by increasing the temperature alone should increase the clearance, so that the high temperature normal flow arm will had a higher URR rate, almost 77% patients able to achieve that. Coming to the baseline standard of care, in the baseline standard of care, only 70.5% able to achieve the KT/V of more than 1.2. So this is because of reasons being, one is the volume of distribution of urea. So the higher the volume of distribution of urea, the dialyzer we use in the government setup is standard 1.3 meters square. We didn't adjust according to their body surface area. So it may be one of the main reasons we were not able to achieve 90 degrees, 90%. That is the one reason. And all the patients have a same dialysis we used. And another doubt raised by the reviewer is whether the URR will change during the reuse of the dialyzer. So they have done a study in after the hemo study, they have done a post hoc analysis. So they come to the conclusion that up to 15 reuses, the change in urea will be only 1 to 2%. URR will be only 1 to 2%. So the reuse will not affect the clearance, and thereby it will not influence the study outcome.
Yeah, I think that was established even in the guidelines, and you mentioned in the paper that you discarded the dialyzers if it was less than 80% of the fiber bundle volume. So once you are above 80%, the urea clearance is 90% of the manufacturer specified KOA. So that part is taken care of.
Yes.
Dr. Shakti, a very, very good study, but it's a pilot study to know whether we can reduce the dialysate flow rate by increasing the temperature to 35.5. So is this removal of urea is similar to all other phosphorus and the middle molecules, or it will be any difference?
So that because actually this see what the Stokes-Einstein equation says that basically the rules apply only to low molecular weight solutes, and the particle should be of more of a spherical one. So these are the two assumptions made by the Einstein and Stokes.
Yeah.
So actually, if you ask whether the urea is an ideal spherical molecule, no, it's not an ideal spherical molecule. It's a discoid molecule. But if we calculate, we theoretically calculated how much it will increase with the how much the 1.5 degree magnitude of temperature will have an effect over the clearance. It came roughly to some 4%.
If I can add to that, phosphorus is anyway not greatly reduced because of the fact that it grows intracellularly. And since they were using a high efficiency, low flux dialyzer, I don't think middle molecules could have been studied in this particular study anyhow, because that's not the purpose of the F6-HPS dialyzer.
I agree with you, Logo, but because we're extending it to others also, the people have to think that it's the even middle molecular clearance, whether it is not affected, then the longevity we may have to increase, or we have to, first of all, we'll have to increase the size of the membrane or use a high efficiency membrane to clear it. So that will also increase, add on to the efficiency of even a urea clearance will increase automatically with that.
Two additional things which we can ask Dr. Shakti, which I wanted to know, because one of the things is that when you used the 4008 machines, they have brushed motors. They work great when they are new, but after they have run for about 10,000 hours, the carbon brushes start getting worn down. And at 300, you start getting flow alarms frequently. So that becomes a problem. The gearheads wear down, the carbon brushes start getting worn down. And at that stage, it becomes quite difficult. You get frequent interruptions of flow alarms with the 4008 machines. So that could additionally be a factor to be taken. It doesn't happen if you have machines which have electronic non-brushless motors.
Very important question, sir. Actually, what we did is before starting, during the trial period of 1 month running period, we asked the technician to tune the gear head for the 300 ml flow for almost nearly 20 machines. Sir. We did that.
Yeah, so great.
So whether as
Uma
compared
is
to what the
muted.
machine says.
Sorry, Uma, I didn't hear your question.
So whether they've used, because if you use an arterial pressure monitor and then you can measure actual blood delivered during the dialysis as compared to what the only the machine shows. So because sometimes there may be a little bit of variation in the blood flow.
Only
What
if
the
the
machine-
tube, but only if the tubing is transduced pre-pump.
Right. Pre-pump pressure, if you attach it, then you'll be able to know. And there are some instances you may have a variability between the two.
Actually, we didn't measure the recirculation in the patients. That is also one of the limitations. But the same patients were carried for each protocols. So it naturally gets nullified. So when there is no problem in the rolling of the pump, we assume that the 300 ml blood flow is smooth.
Dr. Arun Kumar,
Sir, I think we have some questions in the chat box, sir. We can take them up. I
Yeah.
think first question from Dr. Divya is about whether it would have benefited to have a normal temperature, low QD arm, and whether if we prove that to have a good efficacy, then we can avoid increasing temperature, especially in patients with cardiovascular disease.
let Dr. Shaktirajan go first.
Yeah. Actually, we thought of keeping a normal temperature and low flow, but there was ethical concerns, so we didn't go about it. And further, as said by Hegde sir, it is already proven in one study done in the SRMC
Yes.
that by cooling the dialysate, what is that? The clearance will come down, and we want to prove that by increasing the temperature, it will increase the clearance, so that we have kept the higher temperature with a normal flow. But ideally, we should have kept that low flow with a normal temperature.
I don't think
Yeah,
I
but
agree, but the problem is already it's a norm to use normal temperature of 500. So if you
yeah,
reduce it, you have achieved in 80% of the patients, if I correct, but you are aiming at 90% of the patients which achieved. If you reduce the flow, automatically your KT will be much less.
Lesser.
in fact, that is the whole principle of SLED. Even without the study you mentioned, Uma, the
Yes.
early studies with SLED done almost 20 years ago, they used machines, for instance, the
100 to
University of
300
yeah,
dialysate.
300 dialysate flow, and they showed clearly that the efficacy of the process was slower, and they
Unless you
compensated
do it longer,
longer.
8 hours.
Precisely. So I think that question is answered already, and quite rightly, his ethical committee would have had a problem with that.
And so the other questions were on the incidence of dialyzer clotting and whether the high temperature dialysate in a chronic use would lead to dehydration.
No.
The temperature difference was shown was 0.06. So that's no
0.6.
significant change, which Lobo also said that monitoring that also is very, very difficult unless the infrared can. But again, when you have a 300 ml of blood flow, the clotting will be much less. But if you reduce the blood flow, you may have it, but it does not significantly affects if your temperature is varied of the dialysate to 38.5 without any affecting any body temperature.
And there is another point which was actually even made in the paper, and which is known in that it's been mentioned in other studies, that the dialyzer serves as a great heat exchanger, but there is a return line beyond the dialyzer, the venous line, which comes to the patient and which is at ambient temperature, especially in the 4008 machine. In 5008, there is actually a blood temperature monitor into which you put both the arterial and the venous lines, and you can set how much difference of temperature you want to accept with a maximum of 0.5. Now, when you set 0.5, we actually find that the dialyzer temperature automatically gets set above 37 degrees. So ambient cooling is significant in all these situations because, as was pointed out, the ambient temperature is about 25 degrees in the 8C atmosphere. So the return line does cool. And in CRRT, we have found that if you don't put on the blood return warmer on the return line, there is significant hypothermia which happens. So perhaps this study is really going to be path-breaking in showing that a slightly higher temperature is not a problem with regard to events of this sort. In the 3R policy of ISN, they have said reduce, reuse, recycle. So I think this falls into the reduce category. Dr. Satyarajan?
Thank you, sir. Thank you so much for the
And
compliments.
I think the next question is on whether there would be a modification in this protocol for diabetic CAD patients.
Actually, cautiously, we avoided patients with diabetics with symptoms of autonomic neuropathy or cardiovascular instability. But the paper literature says that this peripheral vasodilatation in response to heat stress will not happen in a diabetic patients or with those with chronic heart failure or those with elderly patients. So, in fact, the body will compromise the heat and it will subject the body to heat stress rather than put the patient on hypotension. So naturally, whenever there is also another experiment called lower body negative pressure experiments. So these experiments have proved that. So another doubt is whenever we are removing the ultrafiltration volume, after critical volume is removed, if there is a decrease in the central blood volume, naturally the central parareceptors will come into play and it will cut all the vasodilatory responses. So the previous study says that the diabetics or elderly or chronic heart failure patients may not be as vulnerable to the heat-induced peripheral vasodilatation, but we have to start experimenting in these patients very cautiously, of course.
But whether we need to inform our patients that the ultrafiltration should be lower, otherwise you may have a higher chance of getting hypotension. If the URR is more than 12 ml, then they may have it. So they have to have they have to be strictly reducing the water intake so that they don't get much of weight gain in between the two sessions.
True, sir. But in our study, the average mean ultrafiltration was around 3.5 kgs. But we took only young patients. So as you said, in an elderly, we should be very cautious when we are removing more than 12 ml per kg per hour. Yeah.
Any pilot study would take the patients least at risk. Even a large study like Convince, one of the criticisms is that it's taken the most stable, younger patients with excellent vascular access. So this is absolutely what you would expect to happen. The first pilot study has to take those least at risk.
Yeah, otherwise even the investigator will be taken aback because more hypotension, then you will not be able to go through.
The next question was on whether the same thing would be used if the patient is going to have fever or CRBSI.
No, we didn't test it, sir. So whenever situations of the high risk of hypotension, we cannot try this regimen naturally.
And I think these were all the questions in the chat box, and I think we have answered all the questions. So I request the authors and the panelists to give their concluding remarks, then probably we can complete the general discussion.
I think it's a very good planned novel idea of increasing the temperature, which reduces the requirement of dialysate flow so that we can save a lot of energy when both by the need of electricity and also we can save water, because water now it is increasingly the scarcity is happening, I think, in everywhere, especially in Bangalore we are seeing, and other places also. So it may reduce it. So it is good. It has shown equivocal efficacy is compared to the normal temperature and 500 ml of dialysate flow. You can reduce it to 300, which saves almost around 40%. So it's a good study. I think I salute Dr. Gopal Krishnan and Shakti Rajan, well executed, and it is a very thought out study.
Thank you, sir.
Whether now earlier the Dogredar used to have a redesorbent system. So just reducing the dialysate, we can further do the dialysis with 6 liters or 10 liters of water. because you can reuse or regenerate the fresh dialysate with the reduced carbon system. Dr. Lobo?
Yeah, I agree with what Dr. Hegde said. It's a great study, very well conceived, very well carried out, and it deserved to be in named national reports. And it gives us all something to think about. We all have to look at conserving water, energy, etc. So hats off to Dr. Shaktirajan and Dr. Gopal Krishnan. And as I said, the other message for me was look at, since even in such a well-controlled situation as a study, 70% only achieved a KT by greater than 1.2. So it's a lesson for me to look more often, not once a month, but at every dialysis session, probably at what we are achieving.
I think the machine only will tell you how much is achieved. So you can tag it to it and you can
Yeah,
complete
OCM,
it if required, and so that you can achieve the efficacy in most of our patients.
Professor Gopalakrishnan, sir.
Thanks that this work of MMC has been taken for discussion. In fact, I congratulate all my team members for this. My team is full of youngsters with great ideas, out-of-the-box thinking, and so on. There are many more such newer concepts are in the pipeline. Any concept will gain credence only if it becomes, it achieves generalizability and reproducibility. So my humble request to all the major institutions across the country to join hands with us to go for a multi-centric study. And I would like to initiate on behalf of my team members, let Shakti be one of the key players. And we will kind of formulate, we'll draft a rough protocol and then send it across to those who are willing to take part in this. And after a round of discussion, the protocol can be fine-tuned further. I would like to know the interest of the people who are attending this session. That's my humble request.
Sure, sir.
Sure, sir. Definitely interested.
I think in concluding our general discussion, I'd like to thank Dr. Pratik for his wonderful presentation, all our panelists and the study authors for their valuable contribution to the discussion, and as always, our attendees for the thoughtful questions and taking part in the discussion actively. So thank you. That's all for tonight, and we'll probably meet you next month with another interesting article. Thank you.
Thank you, Arun.
Thank you.
Thanks,
Good night.
Good night.
Good night.
Thank you. Thank you so much.
Thank you, sir.